Good afternoon. It's a pleasure to be here today. We'll just begin by saying that, let's see if we can advance the slides here. There we go. I have no disclosures. The topic that I'm going to talk about in the next 15 minutes literally could consume, a day-long session. So I'm going to go through things fairly quickly. The goal here is really just to orient you to some of the terms that you need to be aware of and to have these slides available to you for your reference. There's really three things that I'd like to cover today. First of all, a little background on Medicare and what the sustainable growth rate was, what MACRA is, and some of the things that you can do in this new coming environment in order to manage it better. So the first issue here is really, how did we get to this point? What are the fiscal challenges that are driving this? This is a graphic from the Wall Street Journal from 2 years ago. And if you just look at 1970, look at the circle, this was the population then of those of Medicare age. And in the orange down below are the baby boomers who at that point in time were just 24 years old. Now look what's happened over the last 45, 46 years. Look at the size of the circle above the line, and more importantly, look what's coming behind. Okay, so in terms of the fiscal challenges that are coming, you've all heard the fact that 10,000 people a day are joining Medicare and so forth. This is what's driving a lot of the policy decisions. Medicare, I'll go just to emphasize here, I won't go through this in detail, but really what we're talking about here with MACRA legislation is the Part B portion of Medicare, that part that concerns physician services and outpatient services. And this is really where the legislation comes into play. So one of the early problems with Medicare as it came on board was how to update the fee schedule. And there were a variety of formulas that came and went, and ultimately in 1997, the SGR was enacted. And this was an idea that so long as the increase in physician costs were less than the growth of the GDP, everything was okay, and the rates could go up according to a formula. But if the rate of spending went above GDP, then there would be mandatory cuts. The first couple of years, the economy was very robust. There were no issues, but then in 2002, there was almost a 5% drop. That led to a political firestorm. And then for the next 11 years or so, there were 17 acts of Congress to stop this. And anyone who remembers those days, it always got nervous at the end of the year, what were we going to get paid the next year? So this led to a lot of uncertainty in terms of how we got paid. Meanwhile, the Medicare budget and outlays just continued to rise. The arrow that you see here is where we are today, which is about $560 billion with a B dollars that are spent on Medicare. And just to frame that, when you hear a program saves $100 million, you're saving 0.02% of the budget. So just to give you an idea of what we're talking about. And this is today where we're at 14% of federal outlays. In 2015, we'll be at 27%. We're at about 50 million members, and in 2030, we'll be at 82. So this is the titanic force that is driving the policy decisions. Put up against that the variance in care. This is Bob Hindle's slide on nuclear cardiology, but we could show this on other modalities. Up here in the Pacific Northwest, the rates of nuclear testing, for example, are very low. Outcomes are great, but in other areas of the country, we do a lot of testing and we don't have the outcomes to show for it. So we're spending a lot of money, not necessarily getting the value, and the population is increasing. So the seeds for change really got sown in the Affordable Care Act, and we think about that as access to care, but also in that legislation were a variety of programs that we're probably familiar with back home. Things like readmission penalties, creations of things like accountable care organizations, bundling programs, physician value-based modifiers. These are all programs that are in place today that had their start with earlier legislation. So whether you're aware of it or not today in terms of physician fee schedules and so forth, up to 9% of what we bill is tied to some one of these programs. And this is where we stand today just in terms of what's at risk. So what lies ahead with respect to MACRA legislation? So MACRA is the Medicare Access and Children's Health Insurance Program. And this really set the tone for us moving towards a quality and value-based system. I think what's really interesting about this piece of legislation is what I've got highlighted in the black. This passed in the House 392 to 37 and in the Senate 92-98 in 2015. Tell me anything else in Congress that comes even close to getting this type of consensus. So this is a bipartisan move towards this legislation. So as we get into it and we see all the complexity and details and concerns, this is not going away anytime soon, based upon the mandate that the voters or our representatives have had for it. So what's coming? What does MACRA mean besides relief from SGR? So the dynamics of this are very simple. As providers, we will be evaluated in one of two paths for the performance that we have in terms of taking care of patients. There's something called the merit-based incentive payment system, which I'll speak to in a few minutes. And then there's the other camp, which are alternative payment models. Alternative payment models are risk-bearing contracts. You may be involved in them today in your organizations, things like next generation ACOs, primary care plus, some of the track 2 and track 3 shared saving models. And in these sort of bundled arrangements where organizations are taking risk, there is a separate way of evaluating physicians. Most physicians, because they're not involved in these pathways, will be evaluated by the MIPS system, and it's anticipated that this will cover 90% of providers. So how does this work? We go through and we provide the care that we provide today, but we're going to be evaluated on 4 different domains. All the existing programs that you're familiar with, PQRS, meaningful use, and so forth, those all get sunsetted, those go away, and they get reborn in this MIPS program. There's another domain called clinical practice improvement, and I'll show you this graphically in a moment. But basically, Medicare will be accumulating data about our performance and how we take care of patients and evaluating us. Now, what's very interesting about this is this legislation as to how this will happen was released for comment in April, 460 pages in the Federal Register. The final comments will come through in July, and it will be enacted January 1st. So if you're feeling at a loss, like this is coming very fast and very complex, you're right, because it is. But this is, what's coming towards us. Those who are involved in these alternative payment model payments will not be subject to the MIPS evaluation process. So graphically, there are 4 domains. There's a quality domain, a cost domain, advancing care information, which is essentially electronic health records and meaningful use, just redefined, and then clinical practice improvement activities, which is participating in certain registries. For each of these domains, there's a very complex way that we will be evaluated in terms of how we perform in these domains, and a score will be generated in terms of our performance along each of these domains. The way Medicare will do this is in 2017, they'll keep track of all the patients that we see in terms of Medicare beneficiaries. In 2018, they'll come up with a score, will be compared to our peers, and then in 2019, we'll learn whether or not we receive a bonus or a penalty based upon our performance. So there will be a threshold score, which will be the mean score of all providers, and if you or your colleagues in your tax ID number scored above that threshold, you'll get a bonus. If you scored below that threshold, you'll get a penalty. It's budget neutral, so there will be, winners and losers, but it's a zero-sum game in that regard. This is what it looks like, again, graphically, a 4% increase or a 4% decrease up to that in year 1. And you can see by 2022, 9% will be at play based upon clinical performance. So just to put this all together, this is kind of the money slide, literally, in terms of what this MACRA legislation looks like over the course of the next few years. So if you're an alternative payment model at the bottom, you go about your typical business and you will get a 5% increase on all of your physician fee payments over the course of the next 5 years. If you're not in an alternative payment model, then you'll be subject to evaluation, and this will range from 4% plus or minus up to 9% plus or minus by year 5. In the meantime, the fee schedule that we have has an increase of 0.5% until 2019, and then it freezes. And then thereafter, in 2026, it picks back up. So what do you do? How do we tame this beast? What can you go home with today, aside from just some knowledge about here, the freight train's coming, what can I do? So here's just a couple things that I think that you can think about. First of all, how does Medicare know who you are? Okay, there's a couple ways. Number one, if you provide care to patients, you have a national provider identification number, an NPI number. You are in an organization, you will have a tax ID number. And Medicare does a lot of its evaluation of performance based upon the tax ID number, the collection, the business collection that you're in. Now, you may be in a large organization, and as a cardiology group, for example, you may be in a tax ID number at your home organization that also has gastroenterologists and primary care physicians and rheumatologists and so forth. So the construction of your tax ID number is going to become important as we go forward. Also, within your tax ID number, Medicare knows that you're a cardiologist or an internist or whatever specialist based upon something called taxonomy. And that classification is usually done by one of your clerical staff in the billing office somewhere. So it's another area that is something that really needs to be evaluated within an organization. Medicare today produces, based upon your tax ID number, something called a QRUR report. And if you've not heard this term, it's something that we're all going to need to know. This is the Quality and Resource Use Report. This is produced twice a year. There's a mid-report and then an end-of-year report. And this is how Medicare keeps score. This is how it is determined whether you and your colleagues in your tax ID number are performing better or worse than others. I think we're having a little technical difficulty here. Let's go back here. So let's say a patient comes in with an acute myocardial infarction, and you and your colleagues take care of that patient, and the patient does well and goes home, and you care for that patient for a year. That's an episode. That MI triggers billing in Medicare, and they do a look back for a certain period of time, and all the costs that happen before the MI and all the costs after the MI are, through a very complex mechanism, attributed to various members of your tax ID number. How well that patient did versus how much you spent on that patient are then benchmarked to your colleagues across the nation, and the score is developed. This happens today, and this is what a QRUR report looks like, but to kind of take some of the complexity out of it, all the blue dots are all the tax ID numbers of various providers across the nation, and in this example, that little red dot is just one tax ID number. Ideally, if you were a low-cost, high-quality provider, you would be up in the northeast quadrant, and if you're a high-cost, low-value provider in terms of quality, you would be in the southwest quadrant. And it's based on this that the scoring is generated today. This is going to be the basis for how payments come forth in the MACRA environment. So again, what can you do besides just start educating yourself and your colleagues and your peers on this very complex legislation that's coming at us very, very quickly? ASE has webinars online on this, so I would encourage you to, go to the website under advocacy, and you can hear and read about the details of this. But just a couple of simple things that you can go home with today and ask some questions within your organization. First of all, is the taxonomy correct? Is everybody labeled the right way they ought to be within the organization in terms of their professional designations? The QRUR reports, those need to be looked at. And then coding becomes very important because all of these diagnoses are adjusted based upon risk, and that is all claims-based. So just practically speaking, at your institution, hospitalists take care of patients with heart failure, cardiologists take care of patients. Who orders more echoes? What's the cost? What's the outcome? That is available information today through a QRUR report. How many echoes do you get a year for an MI patient? What's the variance within your group? This is available to you today. How sick are the patients that you take care of? This is also, again, code-based and so forth, and you can get this information today, and it's going to be very important. So just moving forward, I think the message here is that practice variance is going to have to be reduced if we're going to be successful in the future. Pathways are going to be important. The care we're doing delivering is being monitored. And I guess the way I would close is with this. The revenue that we receive to do the work is virtual. At a stroke of a pen, it can go away. We've just seen that. But yet the costs are very real. The overhead, the staffing costs and so forth. We can't shed costs. We have a responsibility to take care of patients, but the revenue that we have to support that is very vulnerable, and we're going to have to enter a new era of accountability in how we match the two. So with that, I'll stop, and thank you very much.